So it's my pleasure to be here today. This has been really stimulating, all different kinds of things that I don't usually think about. I'm going to present data from a project that spans between Michigan, Rand, UCLA, and actually other places, and that Masheed has been heading up with several of us, including Jason and several colleagues at Rand. It's about the relationship of high hospital occupancy with outcomes for older Medicare patients. And it focuses upon hospital crowding, that this is a big challenge facing US healthcare, but it's been mostly studied in emergency departments, showing increased mortality, reduced quality of care, and impaired access to care during periods of crowding. But there have been relatively few studies actually looking at what happens when the inpatient setting is crowded and there's increased demand for resources. And those studies that have been done have largely relied on problematic measures of hospital occupancy. And so the main issue here is a better measure of hospital occupancy. And I don't need to convince anyone in this room that there is tremendous interest in the outcomes of what occupancy might be related to, especially readmissions with hospital value-based purchasing programs and others that have focused economic value on what we clinicians have known is important for a long time. So at UCLA, I'll get an email like this several times a week, such that it probably has lost its effect. This is the one from University of Michigan. It's on high occupancy today. There are 32 adult patients waiting for beds. What can you do to move your patients along? And this is really the basis of this work, that hospital mortality and readmissions are increasingly a focus of improvement, but there's this gap that we don't know how those are affected, if at all, by busyness within the hospital. And answering this question really requires that we understand what's happening with occupancy on a daily basis, not across months or across years, the way that most places measure it. And the conceptual model, at least the model that led to the R21 that Masheed wrote, is that high occupancy would lead to increased nurse-to-patient ratios, increased patient-to-nurse ratios, and other sets of stressed resources that would produce premature discharge or reduced quality of care, leading to either readmissions or increased mortality, leading to increased hospital charges and increased length of stay. So, or perhaps decreased length of stay, depending upon one's perspective. But the underlying theory is that if your hospital is full, your outcomes, your process and outcomes are probably not going to be as good. And this fits directly into this acute care continuum approach, because what happens in the emergency room is directly impacted by how many gurneys are sitting along the halls, which at UCLA is, there is no hall that doesn't have a gurney at all times, even in the evenings. That then affects the hospital care, that then probably affects these transitions of care back into the ambulatory setting. And can you actually match these up? So the objective of this study was to evaluate the impact of hospital occupancy on outcomes for older Medicare recipients that had either myocardial infarction, heart failure, and pneumonia. And it's not random that these are the three conditions for which Medicare is paying on readmissions. The data set used is this is a population-based retrospective cohort analysis of linked hospital and patient databases. The data set is from OSHPD from California. Why? Because OSHPD data are good. Many other states have good data too. But in OSHPD in California in 2004, there was a decision made that patient-to-nurse ratios couldn't exceed a certain number, and so in part this was done to test that. I'm not going to present that today, but one does have static nurse-to-patient ratios that has been taken up by a number of other states since then. The data are combined with California Vital Statistics, and we have both the inpatient files and the hospital characteristics file for analysis here. So as I mentioned previously, the way that occupancy was looked at in hospitals was to look at the number of licensed beds, look at annual averages or perhaps monthly averages or weekly averages, and then at times to look at number of staffed beds. But these numbers are known to be unreliable. In fact, so much so that if you ask OSHPD to calculate these, they won't, because they don't believe the data that they're getting from the hospitals. So the approach being used here is to calculate a relative measure of occupancy. The thought, a sensitivity analysis was done using a somewhat absolute measure as well that we can talk about, but it especially attempts to measure occupancy at 3 points in time. It wants to know on the day that a patient is admitted, what was the hospital occupancy? What's the occupancy mean across the patient's hospitalization? And what's the occupancy on the date of discharge? And it includes patients on their date of discharge. And this is something controversial. You could say, well, if they're being discharged that day, maybe you shouldn't count the bed as being filled. And a sensitivity analysis was done to exclude those patients. So the way it's done is that the daily census for each hospital was calculated by looking at each patient's admission date and their hospital length of stay. And we then counted up the number of people within the hospital on every day, and then looked at 121-day windows. So 60 days prior to any day and 60 days after that same day, and looked at what the maximum occupancy was over that period of time, and that's the denominator. And then we assigned for each occupancy a percentile such that it actually goes 0 to 100. This is your percentile occupancy during that 121-day window. So it's a shifting percentile of occupancy that tells you for every hospital in California for every particular day, how filled were they. This only included, maybe it was on the prior slide and I missed it, patients who were on the med-surg service, so it excluded patients in OB and psych and non-acute care beds. And so what we were able to construct are these 3 hospital level variables of occupancy percentile on the day of admission, occupancy percentile averaged over the admission, and occupancy percentile on the day of discharge. And the inclusion criteria for this study are people 65 and older. You have to be fee-for-service Medicare. You had to come in through the ER with MI, heart failure, and pneumonia. You had to have a length of stay of less than 50 days, so we weren't looking at the outliers. And hospitals were only included if they had 100 or such discharges over all the years of the study. You're excluded if you were discharged to a prison, to hospice care, or transferred to another acute care facility. And we did logistic regression clustering by hospital ID, predicting the effect of hospital occupancy on in-hospital mortality and 30-day out-of-hospital mortality, adjusting for patient-level variables, age, race, gender, severity of illness using Charleston, SES using zip code, admission month, day of the week, and year. And the hospital level variables of size, region, ownership, teaching status, and urbanicity. I'm going to come back to this point about adjusting for hospital discharge location later. So here's the study sample. There's 383 hospitals that are included, 1.8 million discharges over the time period. You see that about 31% of the patients were 85 years and older. They tend to have more hospitalizations. 53% were women, almost 70% white, with 14% Hispanic. These are hospital characteristics, so 73% nonprofit hospitals, only 8% teaching hospitals, and 6% rural as opposed to urban and suburban. So these are the results. This first result actually is where the patient went if they were discharged based on the hospital occupancy at 3 points in time. So these are the fully adjusted models. The reference here is the patient going home. So I'll just walk you through. If your admission occupancy compared to going home was unrelated to whether you went to a SNF or other sort of rehab facility, and you were slightly less likely to go home with home health if you had higher admission occupancy. As far as mean hospital occupancy goes, the same relationships hold. There's basically no relationship between mean hospital occupancy over your entire hospitalization compared to going to SNF versus home, and you're slightly less likely to get home health if you go home compared to home if your occupancy is higher. However, if you get discharged on a high occupancy day, you are far more likely to go to a SNF than you are to home, and more likely to go home with home health than you are to go home. So hospital occupancy itself affects where you go. This is sort of a preliminary piece of information that will come into play soon. But this is the main finding, and this is what happens to to mortality based on hospital occupancy. So just to reorient you, this is admission, mean, and discharge day occupancy. This is occupancy from 0 to the 100th percentile, and this is 5%, 6%, 7%, and 8%. As you can see, it's relatively flat, though significant, the relationship between admission hospital occupancy and whether you die in the hospital. But notice, if it's sloping, it's downsloping. More profound mean over the hospitalization, and a pretty remarkable 9% down to 5% mortality difference between the least occupied day over a 4-month period and the most occupied day over a 4-month period within your hospital. I might point out this is exactly the opposite of what was predicted in the model. That's why we're presenting it to this group, to tell us why. So you might say, okay, so what happened with the patients who were discharged? So this is what happened to the patients who were discharged. Occupancy admission is essentially unrelated. It is unrelated to mortality during 30 days after discharge. Average occupancy is also unrelated, but occupancy on the day of discharge is slightly, but less than inpatient mortality, related to an increase in mortality after discharge.
Neil, does that include inpatient mortality and 30-day?
It does not. This is you made it to discharge 30 days after discharge. Yeah. Now you could have been readmitted during that time and died, right? But this is 30 days post discharge. Okay. So these are the main findings. So the result summary is that inpatient mortality appears to go down the busier that your hospital is, and outpatient mortality goes up if on the day of discharge your hospital is more full. So in conclusion, basically, so higher hospital occupancy and occupancy on discharge are associated with lower in-hospital mortality, and higher occupancy is associated with higher out-of-hospital mortality. So this is, we think, an important piece to fit into this map of ER to hospital to home, because it probably is showing some important relationships. What is it about relative inpatient occupancy and discharge location and inpatient and outpatient mortality that's actually going on? We need to understand how these relationships work in order to guide both policy as well as hospital interventions. So some of the next steps would be to figure out, why do hospitals appear to perform better when they're stressed? Is it decreased length of stay with fewer procedures in the hospital that are causing fewer deaths? There's a little bit of evidence of that. Most of us who work in hospitals hope that that's not the case. Or are we shifting some of the in-hospital to out-of-hospital mortality? Clearly, it appears that some of it's being shifted, but you're not making up for the in-hospital mortality savings with the deaths that occur after discharge. So actually, I think I'll probably stop there. So it's making, I think it makes this model much more complicated. So is that a good place for us to ask for questions?
Yeah, absolutely.
Or actually, explanations would be good.
You know, did you look at like overall mortality to try to see tease out, or are we just sending people out earlier just to, because it looked like the difference here is about 4%
Right.
between 1 and 100, and the difference in the next slide was only a difference of about a couple percent. So it doesn't seem, not even that, maybe 1%.
Right.
So I'm assuming that overall, like if you looked at death overall within 30 days, you would still see this kind of counterintuitive overall finding.
Right, yeah. So whoops, I think it's actually at the end. But that's exactly what you see.
Okay, so if you include them both. I guess one of the questions I had as you were talking was, like if you took like let's say a diagnosis like AMI, and could you guys empirically just figure out if length of stay is shorter during high occupancy? So AMI, there's lots of data about variability. Some people will go out within even as short as like, less than 48 hours now, all the way up to like, it can be like a 5 or 6 day hospital stay. Could you like see if length of stay for a common diagnosis, all things considered, changes?
Right. So actually, Jason or Mashi may be able to answer this better than I. We did look at the relationship with length of stay overall, but not on a condition level, although that's a really good idea. Yeah.
Do you have any thought about whether your counterintuitive graph really highlights or outlines performance characteristics of busy hospitals versus less busy hospitals?
So we have thought about that. So hospital is accounted for individually in these models.
So in other words, if I live at a 30% occupancy rate and move to an 80% occupancy rate, that's my performance?
Right.
But if I live at an 89% occupancy rate and move to a 99% occupancy rate, that's also my performance?
Basically, yes. In fact, we included as a variable how much variation there is in your occupancy rate, and it actually was not an effect modifier. Beyond that, when you look at the absolute occupancy in there, it really changes these numbers very little. You want to speak to that?
So, yeah, definitely the problem with the relative measure is that the min and the max can be either very close together or very far apart. And as in response to a reviewer, actually, we did control for your overall level of occupancy as a percentage, for example, not relative, but just over the course of a year or something. Like, what was your average percent occupied over the year, or something like that, and control for that as a non-time varying variable. And it really didn't change the effect of, so that's sort of capturing how absolutely occupied you are, and this measure is sort of capturing how occupied you are relative to your normal status. So if this measure is higher, you're more occupied than usual. If it's lower, you're less occupied than usual. So this is more like capturing sort of short-term or more within hospital variability, whereas the absolute measure is capturing more like absolute percent occupied, and controlling for that variable didn't really change this very much. So, I mean, I think is that kind of related to what you're asking?
I think so.
Yeah.
I'm halfway through formulating this thought, and I hope you can formulate the other half. But that occupancy discharge, it's not actually discharge.
Right.
It's that for the people who live, it's a discharge. For the people who die, it's a death.
That's exactly right. So
and the causality for
So you're less likely to die if your hospital is full.
Yeah.
Or are you less likely to die if you're discharged? Period.
You know, I'm less likely to die on that day if my hospital's full.
Right, on that day.
I may die the next day when it's less full.
Maybe, yeah, yeah, right. But on that day when the hospital is most full, you are less likely to die.
Yeah.
You did show that if the hospital was more full, more people went to subacute care rather than home.
Exactly.
Do you have any subgroup analysis that says that maybe we're putting people in subacute care that would have gone home and died? Is there, I mean, are they being more closely monitored?
So we're just,
Mediation analysis. So, Jason, do you want to talk about the mediation analysis we did with care disposition location?
Yeah, so if you do a mediation analysis where you're trying to see what percentage of the effective occupancy is attributable to your discharge location, you do find that some of it is attributable, like maybe 20 or 30%. But of course, it's not perfect because I think in that case we had categorized it into either you're discharged to home or not, and I'm not sure we did this with respect to the mortality outcome.
Right.
I think we did, but yeah, I think
it actually doesn't affect this outcome at all. It only affects this one, right?
was that what it was? Yeah.
Right,
So,
because now, but I think that, I don't know, was that whose question was that? That you're asking a different question, that could you have not died but been discharged? Instead of dying, could you have been discharged somewhere?
Yeah.
Right, but they would end up in here, right? I mean, I guess it's possible you would die in the hospital but not die in the subacute facility, but that's hard to fathom. Anyone else have explanations for this?
Can I like Bob's question though, like, so isn't there some endogeneity that like if you die, your occupancy goes down? Like, I guess that's, is that what you were trying to get at? Like, because when you mentioned it, then I was suddenly like, I don't understand, you're right. Because you're
Go on.
dead, so your occupancy in the hospital has gone down, right?
that would happen the next day.
That would happen the next
Yeah,
day. It wouldn't count.
Yeah, because it's only daily level.
Yeah, but I mean, so in part that was taken into account with the sensitivity analysis. So this is if you don't count your discharge or death day as an occupied day. The analysis was run that way. But in fact, it really doesn't have much of an effect. So I don't think that's the explanation necessarily. So I guess we should be happy when our hospitals are full.
It must just be California.
There you go. All right, any other questions? So Mashid has proposed to try to understand this by doing a mixed method analysis. It really needs to be understood.
Yeah.
Yeah, so it's an R01 that hopefully the NIA will review in June. And the idea is to validate our measure of occupancy, because this is unvalidated and part of the problem, potentially. So this is going to be done in 50 California hospitals if it gets funded. And then we're going to try to understand, so we've looked at a number of outcomes, and these results are an aggregate basis. And when you look across hospitals, there's a good bit of variation in how well or poorly hospitals perform in the setting of high occupancy. And we want to kind of understand those hospitals that are doing really well. What are they doing differently so we can benchmark those practices? So, and that's the qualitative piece of the project. Thank you so much.